Welcome back to another video in the anatomy series. So far we've looked at anatomical planes and directions and their corresponding axes. We've looked at some of the anatomical and directional terms that you've been introduced to or you'll need to use in the program going forward. And in the last couple of weeks we've been looking at the shoulder. This week we're going to look at the elbow joint in a little bit more detail. We've mentioned it very briefly over the last couple of weeks because some of the muscles cross over the shoulder and the elbow joint, or the glenohumeral and the elbow joint. But this week we're going to focus a little bit more on the actual joint itself. So let's jump straight into it using complete anatomy. As always, you can follow this along yourselves. You've got access to this via the library. If you've got any problems accessing 3D for Medical Complete Anatomy, then please let your tutors know. So here we are looking at a stripped down view of the elbow joint. You can see that it's relatively simple perhaps compared to the shoulder joint, but it's no less important. It's a synovial hinge joint primarily, and certainly in terms of the articulation between the humerus and the ulna. So the three joints include the humero-ulnar joint and the proximal radio-ulnar joint and the radiocapitellar joint, or the radio-ulnar joint as it's sometimes known. The elbow itself has extreme importance in activities of daily living, quite often within certainly orthopedic and rehabilitation circles. A lot of focus is put on the knee and gaining the full extension, otherwise walking can't occur properly, and that's completely true. And sometimes the elbow is sort of a poor supporting actor in that discussion, but actually it's very important that the elbow maintains its ability to flex, because its function largely, in fact the whole limb is a functional limb, but it's mainly about being able to get items from far grasp and bring them towards the mouth, or in terms of maybe personal hygiene, being able to reach. And you need at least 110 degrees flexion for feeding and probably 65 degrees of flexion for personal hygiene reasons. So it's very important that we maintain and sort of focus on range of movement and ease of movement when thinking in terms of rehabilitation, certainly. The radial-ulnar joint, as I said, plays no part in elbow function, but obviously is very important in terms of the forearm. Initial sort of view, you'd see that there is a sort of deviation from what you would imagine might be a straight line from following the humerus. This is called the carrying angle, and in males it's sort of 10 to 15 degrees and 15 to 25 in females. They're very broad figures. It can affect biomechanics near full extension, but it rarely has any clinical significance. It's worth just mentioning at this stage that you should probably be aware of the nerves that track over the area, and I've left them on just initially, although some courses may not focus heavily on the neurology. They do feature quite superficially around the elbow joint. Four nerves that we're primarily concerned about in this area will be the musculocutaneous nerve, which is feeding the combination of BBC, which is brachialis, coracobrachialis and biceps brachii. And then we've got the ulnar nerve, the median nerve, and the radial nerve, which are sweeping around the elbow joint, as you can see here. So we've moved the nerves away, and we can look at a little bit more detail at the elbow joint itself. Superiorly, we have the humerus. Laterally, we have the radius. And posteriorly in this view, although medially in an anatomical view, we have the ulna with the olecranon at the back here, which is the sort of bony prominence at the back. Not so easy to palpate the radial head, but with a little bit of forearm flexion and pronation supination, you can get a feel for that pivot joint functioning. Major ligament stability is provided by the fibrous capsule, which is reasonably strong, and the ulnar collateral ligament and the radial collateral ligament around the outside. There's also an annular ligament surrounding the radial head. So having moved some of those connective tissues away, we can now have a closer look at the articulation of the joint. And from that angle, you can see that it's very deep, stable, good bony congruity, which allows for a pure hinge in this position. This area of the humerus here is called the trochlear, and this area of the corresponding notch or fossa or dip in the bone here that you can see is called the trochlear notch. So let's add some muscles back in, and if we start to build this picture up again, we begin to see that the muscles surrounding the elbow joint, well, there are many of them for a start, and the way they sort of intertwine and overlap and support the joint adds to the stability. This opaque area you can see at the front is the bicipital aponeurosis, and if I just highlight the biceps tendon there, we'll get the information to pop up. Biceps, long and short head, act together to supinate the forearm, flex the forearm, and they're also active at the shoulder joint in assisting adduction from an abducted position and upper limb flexion. Now, the attachment point of the biceps brachii is down on the radial tuberosity, and if I just lift the model slightly higher, you can begin to see how actually it is functional in supination, because from the pronated position the radius will cross over the ulna and contraction of the biceps will pull the radius back into the anatomical position. Posteriorly and superficially we have the triceps, and we can see here that there's a common triceps tendon where all of the triceps, the three heads, come together and attach in isolation. There you can see that they attach to the olecranon at the back. And of course they're involved in elbow extension. So if we now hide those and let's take them away, and we'll take the triceps away as well. You can see posteriorly there are no more elbow extensors, apart from a very small muscle here, which is the Anconeus muscle. Now the Anconeus muscle, whilst it is active in elbow extension, actually has a capsular attachment, and what its main role is to pull the capsule out of the way as the elbow goes into full extension and saves any entrapment. Into an anterior view, and a little bit deeper now, we've got the brachialis muscle. Now the brachialis muscle is deep to the biceps brachii muscle, and if we have a look at its action, it is a pure elbow flexor and is regarded as the main elbow flexor. It is of course assisted by biceps brachii, and in that action there you can also see right next to it is a very long muscle with a reasonable muscle belly and a very long tendon, which is brachioradialis. Now brachioradialis is another elbow flexor, but it's actually more active when the forearm is in a mid sort of supination pronation position. So it's not really a neutral position as such, but it's in the mid position between pronation and supination. So if we hide brachialis and we hide brachioradialis, we get a closer look at some of the deeper muscles. We'll get rid of the bicipital aponeurosis as well. And we can just have a look at some of the deeper muscles. And you can see in this position that there are many forearm muscles. Often we learn them together when we're studying the wrist, so that over a couple of weeks you'll have a go at being able to sort of store some of these muscles and their actions. Primarily, we would expect to see the extensors on the lateral side and the flexors on the medial side, and they would work together in groups to help wrist adduction and abduction, and we'll look at those in the next video. So right now we'll just consider the extensor carpi radialis, extensor carpi radialis longus as it happens, and you can see how that travels from the lateral epicondyle down towards the wrist. Just behind it we have extensor carpi brevis muscle, which is a shorter version, and we have the extensor digitorum muscle, which is the extensor of the fingers. If we move medially, apart from this small pronator teres muscle, flexor carpi radialis muscle, palmaris longus muscle, and flexor carpi ulnaris muscle. They're worth mentioning in terms of the elbow simply because they're often injured, and most commonly you may hear the term tennis elbow and golfer's elbow, and they're terms that are used to describe either lateral in the case of tennis elbow or medial in the case of golfer's elbow epicondylitis. The other movement available around the elbow is pronation supination, and we've already mentioned the biceps has a role in that. I mentioned just before the pronator muscle. So this muscle, when it contracts, pulls the forearm into pronation. And supination, as we've mentioned, the biceps is involved, but there's also a supinator muscle just deep inside there, which is contracting to bring the forearm back into the anatomical position, or supination, if the elbow is flexed. It's always worth remembering that when you look at pronation supination, it's better to examine this with elbow flexion. With elbow extension and in the anatomical position, then quite often there is a complication involved, as shoulder rotation could come into play. So if you want to isolate the shoulder, take it out of the pronation supination action, then elbow flex at 90 degrees and elbow testing in that plane is recommended. So that's an overview of the muscle. We looked at the bones of the joint, we looked at the muscles of the joint, and we talked a little bit about functional movement and stability. Next week we're going to move further down the forearm, look at the forearm flexors and extensors in a little bit more detail, and look at the structure of the wrist and the hand.